Welcome again to Cutting Edge Health. And today what we're talking about is, does an ACL tear have to be fixed with traditional surgery? As you saw in that original picture, it is traditionally treated with an ACL graft. We're going to explain to you about what is an ACL, one. Two, what are the traditional ways to repair it from a surgical standpoint? And three, a paper that actually talks about an interesting way to be able to treat ACL tears and how you can be able to get back to leading the life that you deserve sooner than not. If we haven't met, I'm Dr. Orlando Landrum, and this is a channel that we purport to be able to try to explain typical scientific principles on how to be able to improve your health, your pain, and your function. And today we're talking about the knee and something that's called an ACL tear. For those of you who have heard about it before, it's an anterior cruciate ligament, We're going to explain what that is. But first, let me give you some insight about the paper that we're reviewing so that if you wish or your other healthcare providers wish to kind of take a look, it's the following paper. It was published in the Biological Orthopedic Journal, and it is the image-guided injection of the anterior cruciate ligament tears with autologous bone marrow concentrate and platelets midterm analysis from a randomized controlled trial. So I know that that's a mouthful, and as I have talked about before, what we're going to do is do the following. So we're going to explain it to you so you get exactly what it is that we mean. But basically, it's a trial that looked at a way to be able to treat ACL tears using a percutaneous approach, using cells from the patient's own body, not extraneous, to be able to repair a tear as good, if not better, than what you may have gotten from surgery. And what they did was randomized two groups. So one got the fancy treatment and one group got traditional exercise, and they saw how well did these groups improve or not improve. Okay, so for those of you who are watching, if you have questions, please jump in. Be happy to answer them during the whole thing. Just so you know, the group that actually put this together is the following. It's the group that's in Centeno Schultz Clinic from Regenerative that's present in Broomfield, Colorado, as well as doctors that are present from Des Moines, Iowa, who combined together to really be able to produce this research. It's an interesting article, which I'm going to try to do my best to give due justice. One of the first things that they talk about is the incidence or how likely is an ACL tear to occur. For those of you that follow sports, you know that it's pretty common in football, but it can occur in other sports. And as the weather starts warming up and the NFL draft comes along, we're hearing constantly about ACL tears and how long it takes to kind of get back into the ability to be able to do the things that you want to be able to do. But to give context, outside of professional athletes, it's actually pretty important that you have an ACL because it provides stability in one mechanism. But ACL repairs using surgery have shown to have an increased likelihood of osteoarthritis occurring and occurring sooner than what it would if you hadn't tried to treat it with surgery alone. So let's talk about this a little bit. So the anterior cruciate ligament is a stabilizer of the knee that prevents anterior translation of the tibia, and it serves to restrain tibial rotation. It was most commonly injured ligament in the body, and it happens about 200,000 cases each year in the United States, with about 150,000 surgeries performed yearly. That was from that paper, right? So it sounds fairly fancy. Let's explain it to you kind of in a breakdown in the context of a model. So if we were to take a look at a knee model, right, what we can be able to see is we see this knee that's in place. We can tell that this is the front portion of the knee. This is the shin bone or tibia. Here is the femur that's present. This is the aspect of the quadriceps tendon, patella tendon, and underneath this is the areas of the meniscus. If we were to move this to the side and we can be able to see a little bit more deep, we can see the meniscus, we can see the patella off to the side. And as we stretch this out, we can be able to see the ACL and PCL ligaments that exist there. And those ligaments are what prevent the knee from being able to move forward at times as well as rotation. And it helps provide stability. So we're going to talk about this in a little depth and detail by showing other different pictures, but seeing that model and understanding that that tear that occurs can cause a whole host of different problems with the ability to really be able to have a stable gait. So as we take a pictorial representation or cartoon representation, we can see that same type of thing that we just saw in the 3D model, where in the center we see the patella or the kneecap. Above it, we see the femur or thigh bone. Below it, we see the tibia or shin bone. And then we can be able to see this anterior cruciate ligament. And the reason why it's called cruciate is because it's cross and it's in the front. In addition to this, for those of you who follow some of the things that we talk about in our newsletter and other channels, you'll know we talk about ligamentous injuries outside of the ACL. We talk about the MCL, which is a medial collateral ligament. We talk about the LCL, which is the lateral collateral ligament, and patella and quad tendons specifically, right? But in this context, we're talking about the ACL. So as you take a look, you can kind of see all these different ligaments that come together to support the areas of the knee. We're going to show some pictures which are going to be a little bit anatomical. So for those of you who don't have strong stomachs, you might want to kind of cover your eyes for just a little bit, but we want you to understand the science and the anatomy behind what we're discussing, so that way you can get the significance of this type of treatment that's different than traditional surgery. So one of the papers that really kind of gives us an understanding is present in orthopedics and traumatology, which basically looks at ACL tear, and it gives pretty significant pictures like you would see in an anatomy lab. So taking a look at the very first picture, it looks like the following. So you can see the areas of the femur that's in place. You can see that PCL, and then you can see the anterior cruciate ligament and how it has a couple different bundles that are in place. And those bundles are important for the treatment as well as for the function. You can see the meniscus that sits in underneath this and how it's really deep within the area of the femur and how it provides stability that's in place. We're going to take a look at some other pictures. The next picture is going to show a picture of the knee from the side at the top row, and then the bottom row is going to show it as if we're facing on. So what I mean by that is the top row is going to kind of look at it from the side, if you would, and then the bottom row is going to look as if you're looking straight at it, right? So when we take a look at this next subsequent picture, you can see these ligaments that start and go towards the back portion of the femur, and we can see the components of how the two have that anterior medial and posterior lateral components. And when you bend the knee, you can see that there's a transition that takes place. Down here, you can see the forward, or looking at it from the front, you can see that anterior medial component, the posterior lateral component, and some of this is really fancy language, so pardon me for being too fancy, but I want you to understand how this is treated when you use a needle as opposed to surgery to get to the areas and then help them come back to the way that we want them to be. So again, giving you some more anatomy so you can see it. We're looking at this thigh bone or femur from the side, and we can see now where these ligaments actually insert, which is almost near the back portion of the femur, which is really interesting because when you take and you bend the leg like this, you can see that those ligaments change and they hold that knee from shifting, right? Because if it shifts too far, then we lose stability. So take a look and kind of fix the angle of this in your mind, and then compare this to what you see when we do a repair that's a surgical repair. It looks like the following. So you can see it's different. That angle's different, how it interfaces with the bone is different, how it connects in, and that difference is what actually promotes changes, a number of different changes. And so we're going to kind of explain that in the next few slides. So the first is that when you do a traditional surgical repair, you have the capability that may have osteoarthritis. And what they have found is that 20% of ACL injured knees progress to moderate to severe arthritis within 10 years. And that's compared to knees that weren't treated in such a fashion where 5% of them progressed to arthritis. So in essence, you had a fourfold likelihood of having arthritis if you have an ACL repair, which is quite a bit, because that arthritis that occurs frequently takes people to consider traditional surgery, which is that of doing a knee replacement at some point in time down the line. One of the things that's really not discussed is the number of ACL tears that occur in teenagers, specifically those that have exercise elements like soccer, and how that can, if treated with surgery, can hasten arthritis much younger in their lives than what you would expect. So when we talk about doing an ACL tear, how many of them are stable? And if you can see underneath this kind of purple eval, this study that was referenced previously, it looked at a 5-year follow-up, and it found that about the failure rate ranged anywhere from 1% on average to somewhere around 10%. So 1 out of 10 surgeries that are done ends up having a failure, which that's a bit high. I won't say 10% for all of them, but somewhere within that range, that's 10% or close to it, where you can have a problem after going through surgery and the graft didn't take, and you need to do another subsequent surgery or figure out how do you want to kind of address that. So the actual study that was referenced before, what they did was a fancy way of doing things. They did a randomized controlled crossover study, which is significant. It's seldom that you see a study such as this that looks at traditional orthobiologic or regenerative medicine treatments and does a randomized controlled trial. Normally, when you hear people that are detractors or say, oh, there's not much science behind regenerative medicine, they say there aren't any RCTs. This is an RCT, and it actually does it in a way that is appropriate and the right way to do it. So what they did is they actually had an IRB, Institutional Review Board, approve the way that this was actually put together as a study. And what they looked at was symptomatic patients who had a partial or full thickness, non-retracted ACL tears. So what does that mean again in English? What that means is, so if my hands are a tear, right, and you see the separation that's in place, you can have a partial tear where you only have a little bit of the fibers, or you can even have a full thickness tear, but you don't have a fully separated retracted tendon. If that's the case, there are things that can be done instead, but if you have a full tear and it's non-retracted, it very well may be able to be treated in a percutaneous, or in essence, a needle fashion. So going forward, what they did is they wanted to kind of have an understanding about if you're able to maintain the ACL's natural orientation. So what do I mean when I say that? What I mean is, as you recall, when I showed you those anatomical pictures, the ACL has a certain slant and orientation between the tibia and the femur, in essence, between the shin and the thigh bone. When you do a graft, it changes that angle. And that change in angle has a number of consequences. And some of those consequences include, basically, you have a difference in how the knee moves and how well you can be able to feel that knee in space. And so that's what proprioception means, is that what in essence, we wanted to be able to keep the ability to be able to feel where that knee should be and keep its natural movement and orientation in place. And that's what this type of injection was able to do. So it goes on and explains how the procedure was done. It talks about how they're, from a stem cell component, you're able to isolate cells from that person. They harvested from iliac crest using imaging to make sure things were safe and appropriate. And then sterilely, we're able to isolate it and concentrate it so that the cells were able to be produced of 2 to 5 cc's of bone marrow concentrate. And then following that, they were able to take that concentrate and combine it with the utilization of PRP, or platelet-rich plasma, where they took plasma from that same person, were able to concentrate it and use it under appropriate sterile conditions in the right way. And then following that, they were able to re-inject the areas of the ACL. So what does that look like in a pictorial form? It looks like the following. So on the left-hand side is looking at the knee from the front. On the right-hand side is looking at the knee from the side. And what you can see is a needle that kind of comes in, it's injecting contrast so they can see exactly where they're going to place the cells in the blood and see it hit that ACL and those bundles that we talked about before, the anterior medial bundle and posterior lateral bundle that's in place. And so what you can see is this needle comes in a very minimally invasive way through the patellar tendon. It finds this notch and it's able to inject, and you can see it follows that spread back towards the back portion of the knee, just like I showed you in the pictures before. So you know that we're able to get that spread. So one of the questions that would typically be asked is, yeah, but how do you get that spread when you have a full thickness tear? And what's interesting is when you think about a full thickness tear, is that there still are fibers that are connecting those two halves together. And this injectate is injected and it uses those fibers to reformulate that tendon and be able to make it more robust because it hasn't retracted. It's a really interesting concept and utilization of how can you do this in a minimally invasive way to get an outcome that you otherwise couldn't expect or wouldn't expect to be able to acquire. So when they took a look afterwards, they assessed it with MRIs with both a pre and post treatment at 3 to 6 months in order to be able to see what was going on with the ligaments. First, they identified what the type of tear was, and the type of tear ranged anywhere from, as mentioned before, a partial tear to a complete non-retracted tear, to a complete non-retracted tear of a different type, to complete retracted tear. And what they were able to see is they were able to be able to figure out that the ACL was back to a normative look post. And so what many people would say is, okay, well, it might look normal, but does it act normal? And so that's why there were a number of different outcome measures or studies to look and see the stability and the functionality. And here you can see the bone marrow concentrate treatment, meaning the actual treatment, where it started and then where it finished in comparison to exercise. And you can see that for the most part, it beat the pants off of just the traditional controller exercise treatment group, which didn't have anything done to it. So what you're able to see is that, yes, it provided stability, it provided functionality, similar to what you would get from a surgical response. And what they did was take a look at this over a period of time, including further MRI imaging. And what was found is that they were able to see that the ligament, particularly after 6 months, was back to the traditional view of what we would expect without that tendon tear. So you could see it coming back into a similar space and know that it was a good fit, that it was improvement, and that you got a response. So in summary and conclusion, what they found was the following, is that this fancy study, that the use of the patient's own cells and utilizing this under x-ray, which is fluoroscopic guidance, into a partial or full thickness non-retracted, meaning the tendons haven't pulled apart, were able to result in improved patient function at 3 months. Again, at 3 months. Now, normally, when you talk about surgical repair, you're not talking about a 3-month improvement in function. This completely different, right? So at 3 months, when compared to exercise alone, and the treatment effect, as this study looked at it over 2 years, was sustained and was able to be documented with multiple measures of how well does this work, or in essence, functional outcomes. And it was able to be assessed under imaging that looked at it both pre and post and saw the ligament was live, it was mature, it was robust, and that it was able to really give patients what they needed. What they suggest is other things that they could focus on is, when should this injection be done? Should it be done pretty much close to when the tear occurs, a little bit afterwards? How well do old tears respond? All of those type of things were things that they looked at. But at the end of the day, it's seldom that patients are counseled about a non-surgical treatment that has good outcomes, that has science behind it with randomized controlled trials that actually exist. This is a paper that shows that. It shows the principles of how regenerative medicine can be utilized to provide benefit that we otherwise wouldn't think about. And in this way, you can be able to improve not only pain, but also function and get back to leading the life that you deserve. Again, thank you so much for joining, and we appreciate your support. How we've been able to progress as a channel, and both on Facebook as well as in YouTube, has been huge for us by the support and questions that you guys have. And we really do thank you for tuning in to hear about different topics that aren't that common, but certainly should be something that the lay public as well as other medical professionals should know more about and have the rigor to be able to study so it can improve people's lives. Again, thank you so much and have a fantastic day.